Okay, the modified autism checklist for toddlers, okay? There's a checklist for toddlers, and this is a modified. So the checklist is longer, and the modified is shorter. It's about 25 or 26 questions, I can't remember. And it's parent completed, and, 23, 23, I have it right there. Parent completed, 23 questions, takes 10 to 15 minutes to complete. The sensitivity is high, the specificity is low. Recommended that this be administered definitely no later than the 18-month visit. Some will do it at 14 or 15 months, but definitely no later than the 18-month visit. And if the child, or if there are 3 or greater wrong answers, and this would be a child that you'd be concerned about for autism. Now, when I say the sensitivity is high, basically you're picking up a child who probably will have something going on when they have further developmental evaluation, but in terms of specificity, it's low. Probably about 5% in terms of identifying children who will actually go on to have a diagnosis of autism. So again, you have the child who doesn't pass this, then that would be a child that you want to refer to someone else, to say a developmental pediatrician, neurologist, whoever, referring that child to regional center for developmental evaluation or further evaluation to see what actually is going on with that child. Okay. Okay, this is the ages and stages has a social emotional component. This is a newer component that was added to, and you can, it's 4 to 60 months also, where you can get a sense of where that child is from a behavioral standpoint. Then there's also the child behavior checklist, the Achenbach, that can be done. Now the Achenbach used to be an evaluation that practitioners would use to look at attention deficit hyperactivity disorder. In more recent years, it's fallen out of favor related to ADHD, and more so felt that it actually evaluates whether or not the child is having some behavioral issues as compared to ADHD specifically. Then there's a pediatric symptom checklist, which you can do on children from 4 to about 16 to 18 years of age. Excuse me. And then there's a Vanderbilt scales, which it's pretty short, and it gives you a sense of ADHD. And actually, they use it in, the residents and the attendings will use this at UCLA when they're looking at a potential child, a child who potentially has ADHD. Next slide. Okay, then they're directly administered tools. There's a Denver Developmental Screening Test 2, and this is out of favor. Out of favor in the sense that the feeling is that the sensitivity and the specificity is pretty low. Curious about the Denver is that, what I like about the Denver is that everything is on one page, and it basically has it goes from birth to 6 years of age. Everything is on one page, and I think it's a very good tool for teaching residents about development. If a resident is doing a Denver on a child, and then they repetitively do a Denver on children, say throughout the course of their residency, I think they will do pretty well on their general pediatric boards when they sit for them, because that's, I mean, despite the fact that, again, it's out of favor as a screening tool, but I think it is very good in terms of teaching child development and age-appropriate developmental milestones to someone who is learning that. Then there's a Bailey Infant Neurodevelopmental Screening, the BINS, which is kind of like a watered-down version of the full Bailey, and that's a screening tool that can be done. And these are, so basically you have, where the practitioner is involved in doing something or making observations or administering something to the child, as compared to just relying on parental report. In terms of developmental evaluation and getting a sense of where a child is, a combination of parental report and direct observation or administering some task to the child is really the best if you're really going to get a sense of where that child is from a developmental standpoint. Because if you're just relying on parental report may or may not be accurate. If you're just relying on a tool that is administered by a practitioner, then the child may not be up to snuff on that day. They may not feel like performing on that day, and you may be missing something. Next slide, please. Okay, here's again, the Denver Developmental. Just want to go over this a little bit. Done with a kid, very inexpensive kid as compared to like a Bailey or any other. Birth to 6 years of age, covers the major developmental domains. Takes 10 to 20 minutes to administer. If you have a cooperative child, it's validated on a diverse population. Sensitivity is 83%, specificity is 45%. To me, that's not really bad, but nevertheless, you do get kind of blasted when you talk about the Denver 2. So, next. And the Bailey Infant Neurodevelopmental Screen is done with a kid, 3 to 24 months of age, takes 10 to 15 minutes, sensitivity is 75 to 86%, and specificity is about the same. Next slide. Okay. When you're doing screening on a child, when the results are normal, then you engage in parent education. You're giving the parent anticipatory guidance. You're reassuring that their child is within the normal limits at that point in time. Where there's a concern, then you may want to schedule an early visit, evaluate the child in 2 to 3 months later, and see if there's anything still concerning. If there's still concerns, then you would do a developmental screening. When the results of the screening are concerning, then you would refer that child to a developmental evaluation. You might want to refer for medical evaluation, such as a geneticist, particularly if you notice 2 or more dysmorphic features in a child where there's a developmental concern that you want to see. You want that child to be seen by a geneticist. Okay, next slide. Developmental evaluation is so when you have a child, when surveillance has been done, there's concern, there's screening has been done, there's concern, then you refer that child for developmental evaluation. It'd be by a pediatric subspecialist such as me, a neurologist, early childhood professionals such as regional center professionals, the school district professionals, and they're aimed at identifying specific developmental disorders or giving a diagnosis for that child so that you can get a sense of the appropriate interventions for that child. So, next slide. Developmental evaluations now, the Bailey Scales of Infant Development, the 3rd edition, and, oh, I see there's a typo right there, but I thought I corrected it yesterday, but I guess not, didn't save it. Gazelle, I use a Bailey, I use a Gazelle, and definitely I interject a lot of clinical judgment. I mean, the reality with me is that this is what I do. So, I mean, I diagnose kids in Ralph's and things like that. But, you know, because, I mean, but my point is that the thing is like with the Bailey is basically it's standardized. It's theoretically the gold standard. But the Bailey, you're observing whether or not the child does it. The child gets no credit if they don't do it. But even if the parent says they can do it, if the observer is not observing the child doing it, you know, and to me that's a limitation of the test. But the Gazelle is not like that. The Gazelle is basically you observe it. There's some things that you have to observe the child doing, and you can't give the credit unless you observe the child doing, and you can take parental report. So again, for me, developmental evaluation is a combination of parental report and observation of the practitioner administering the evaluation, and you're putting clinical judgment in there too. Okay, so the Bailey, it's the 3rd edition is 1 to 42 months. I like the 3rd edition much better than I like the 2nd edition. The 3rd edition is, it divides it, it has all the domains divided, so you have the book, and then there's a cognitive, then there's the receptive and expressive language, then there's the fine motor and the gross motor, whereas the other one wasn't divided like that, the Bailey 2. And then you administer them, and you add it all up, and you come up with what they call composite scores in each of the areas. And so you may have a composite score of 90 or 110 or whatever in each of these areas, and you can talk to the parent about their performance in each of these areas. And this is it takes 30 to 60 minutes to administer when you have a cooperative child. If you don't have a cooperative child, I mean, there's some children that I'm chasing up and down the hall that it takes a long time to do. But nevertheless, it's okay.